Didn't meet you though.
Hi, I'm Jeanette Stewart. I'm a nurse consultant with Department of Developmental Services in the
Okay,
West
so-
region.
So you work together?
Yes, I'm a nurse,
Good.
nurse consultant.
Good. So today we're going to talk about osteoporosis, the epidemiology a little basic bone biology, some discussion. I tried to do some case-based learning, as we call it, and talk a little about treatment options, but I didn't want to go into too much detail unless you guys want to. So I have a lot of information, but it's up to us. And also what are our concerns about our treatments and what's on the horizon. So remember, this is our definition of osteoporosis, characterized by low bone mass, structural deterioration of bone tissue leading to bone fragility. So you can see, I don't know, this is very good. So you can see on the left normal bone, and this is osteoporotic bone. It's losing its structural integrity and therefore risk of fracture. So I know you guys know most of this. So you know what, can we put part of the lights out? Is it
We
all
can
or
just
none?
put them up when you need them too.
Yeah, it's just, I think
It's
you
kind
can
of all
see
or
better
nothing.
with the, are you guys okay? Because I'm developing some trouble with my cataracts here. My
This is
husband's
talk
an
on
eye
my
doctor
ears.
and he keeps blowing me off, but that's beside the point. So 1 in 3 women after age 50 will experience an osteoporosis-related fracture, and of course, as you as geriatricians know, hip fractures are the most significant with substantial morbidity and mortality and disability. So these are the main fractures we think of, you know, vertebral, wrist, and hip, but we don't forget arms, lower legs, pelvis, which I think is the forgotten fracture personally, and a challenging one at that. Okay. And stop me anytime if anyone, because we're a small group, any comments. All right, now let me just remember. How do I, okay, I think this is right. So this is just a bar graph of the prevalence of osteoporosis in women over age 50 from 2002 to 2020. Okay, gotta get my, oops, see, this is challenged here. Oh, so total projected number of cases of osteoporosis of the hip in women. So of course, you know, rising, partly demographic issue. And the burden, as you'll see, is primarily in Caucasian women, but not completely. And then men are rising up in the world in this disorder as well, particularly as they grow older. So this is just the graph of U.S. Caucasian women, all the different fractures. So the thing I want to point out is that wrist fractures, forearm fractures, tend to occur earlier in life. So women that are early menopausal or perimenopausal, and that is sort of a sentinel event in our field to look for bone health issues. So they tend to rise in the early 50s and then plateau off, where you see vertebral fractures start to increase in the 60s to 70s and go up with advanced age. And hip fractures, which is this line, if you can see, also goes up in the mid-70s. And here are pelvic fractures, which are also behind hip fractures and lower incidence, but yet increase with increasing age. And there is, by 2025, fractures for women over 50 in the United States is expected to grow by 50%. So big numbers. And this, I like this graph I found recently because it looks at a more diverse population from a big study, I believe it was in the UK, and they looked at different ethnic groups. So on the left, trying to get this, okay, hip fracture incidence by ethnicity. The dark bar is men, the red bar is women. So of course women bear the burden, and Caucasian women, this is fracture incidence per 10,000 patient years. And this is Asian women, which fairly higher incidence of hip fractures, so some of it may be because of geometry of the hip. This is sort of mixed, so Latino population and then African American or Black descent have the least fractures. So that's for hip, and it's very similar graph for overall fragility fractures, which just means all other fractures, vertebral, arm, lower extremity, etc. So that's the most recent and the best data that I've seen. So is our fracture incidence increasing? And this is a study from the Mayo Clinic group, and they looked at fractures on the dotted lines between 1989 and 91, women and men, and then compared it to more current 2009 to 2010. So if you follow along here, so this is hip fractures in women. So this is the prior data, this line that's dotted, and this is before bisphosphonates came out in 1992 when I was in my fellowship. So we started to treat women after that. Good morning. So in the 20 years later, there are actually less hip fractures overall in women. So I think that may be a treatment effect. Men pretty much stayed the same. And this is also forearm fractures and vertebral fractures, which have been increasing in both men and women. So it's interesting information. So fractures are increasing in some sites, but not in others, is what we sort of take away. But still, because of an aging population, the numbers are very significant. And this just shows how fractures lead to more fractures. If you have a wrist fracture, remember I said those are the earliest ones, late 40s, early 50s, perimenopausal, early menopause. This shows your risk of other fractures. So compared to women who haven't had a wrist fracture. So if we just look at spine, so women who had an initial wrist fracture compared to those who didn't, it's almost 2 to 1 at every site. Those who experience a wrist fracture have almost double the risk of experiencing a non-wrist fracture. So fractures beget fractures is the take home here, and also within the first year of having a fracture, your risk of subsequent clinical fracture is elevated 5-fold in the next year, so very high incidence compared to overall subsequent risk of fracture, less than 2-fold over 15 years. So that's just what this graph is telling us. And our treatment rates, at least from 2002 on, seem to be declining. 65% of hip fracture patients were not treated for osteoporosis within 12 months of discharge from a hospital. Probability of medicine use after discharge for hip fracture reached a low of 21% in 2011. So this is, not the most recent data, but it's a bit discouraging, and I think we need to look at newer data. Are we doing any better? Because now many places are having what's called a fracture liaison service, and we sort of have a quasi one here. We try to see all hip fractures either initially in the hospital and follow them to the outpatient clinic. It works sometimes, it doesn't in others for a lot of reasons. Patients going to nursing homes, out into community physicians. So there's a lot of mix, at least in our local population. But we have made an effort here to try and see all hip fracture patients if we can while they're in the hospital. And it seems like face-to-face, if we get in front of the patient or family, we have a better chance of them coming back to us for treatment. But it is a challenge, and it's still very much a work in progress. So why do we get osteoporosis? Let's see, well, I'm not going to go into too much detail, but clearly skeletal fragility and excessive loading on the bone are the main features. So as far as skeletal fragility, do we not reach our peak bone mass? And I'll show you that in a second. and of course, increased bone loss associated with menopause and many other medical disorders. So remember, we reach our peak late 20s, early 30s. This is men and women, and then it's a slow downhill course until, of course, the menopause, where we have that big hit on our bone mass, and then continued slow decline after that. And the curve in men is very similar, except they have a higher peak bone mass, probably because of genetics, testosterone, and a slow decline just like women do, but obviously no menopausal hit. Okay. So this is just a slide to show you, this is the only basic biology, but I think it's important because our medications are based on this understanding. So this is bone remodeling, a sequence of events that occurs throughout our bone, and it's what we call the basic multicellular unit. So within each unit, bone formation follows bone resorption. Oops, hold on. Okay, how did I do that so fast? So in healthy humans, 3 to 4 million bone multicellular units are initiated annually, and about 1 million are operating at any one time. So what is essentially happening, if I can get this right, is there's signals from the osteoclast precursors to resorb bone. So it's called activation and resorption. And the bone is sort of resorbed, and you get what's called a resorption pit. That's what this is. And the osteoclast is the cell that does that. And then there's a reversal phase that occurs, and the osteoblasts start to come in. And the osteoblasts lay down what's called osteoid that has to eventually be mineralized. So that's the formation. And eventually you get mineralization, and the osteoblast becomes an osteocyte and down into the bone matrix. And that's become a more important cell lately for mechanoreception, understanding or sensing mechanical load. So this is several months at each of these bone remodeling units. So when we give our medicines like bisphosphonates and denosumab, which is a ranked ligand antibody, what we're really doing is we're slowing down the osteoclast resorption and filling in these remodeling units. And that increases the bone density and decreases the risk of fractures. A little different from when we give an anabolic agent like PTH, where we're actually forming new bone. So people ask, well, can you really build bone? Well, yes, you can with all our agents, technically. So the anti-resorptive or bisphosphonates, they're filling in these resorption areas. So that's the main difference. And we know bone remodeling, these units, their activity increases with aging and around the menopause, of course, because we lose our estrogen around menopause. Good morning. And that's, for women, a huge stimulus for this bone remodeling. So this just shows that remodeling increases around menopause and postmenopausally, and that's, that's what it's showing. So when you're young, your activation of these bone remodeling units is fairly low. That means after you've reached your peak bone mass. Okay, so how do we measure our bone health? It's by DEXA. You all know about this. It measures the spine and hip, non-invasive, very low radiation. Patients ask me, it's like flying across the country from the East Coast to the West Coast. So it's not, it's like a tenth of a chest x-ray. Patients ask this, so you have to give them something to relate to. And it's our gold standard right now, the DEXA. So what is true of DEXA? So here's your first quiz, okay? There may be more than one answer. It measures bone density in grams per centimeter square, which is an aerial value. It measures risk for fall, measures bone quality and microarchitecture. It gives a T-score, which compares the patient to a young adult mean or control group. So, anybody have any thoughts on the answer?
A and C.
A and C, anybody differ?
A and D.
And D, okay. So it is actually A and D, it's not C. Bone density does not measure bone quality, bone turnover, microarchitecture, matrix composition, degree of mineralization, or of course fall potential. Yeah, it does not do that. So it's what we have, it's the best we have. Clearly there are research technologies that are looking to look more at architecture and geometry, but the DEXA doesn't give us that. And it divides you into, as you all know, into normal bone density, osteopenia, and osteoporosis. And these are by your T-scores. And this is what you all know looks like, the lumbar spine, the total hip, where we measure both what we call the femoral neck. This is this box, and then the total hip. Okay, and we can also put the patient on and get a lateral vertebral assessment, which can be important because if we see some fractures, and you can't always see them on the spine, bone density, because and this goes thoracic through lumbar, and that's a kind of game changer when you know you have compression fractures. So I might be more aggressive in that case. And it typically you have to order it with your DEXA, otherwise there's a whole insurance, we won't pay for it. A lot of times doctors get spine x-rays, lateral x-rays, which is fine. It's more radiation and it costs a lot more to Medicare. But this has been a bit of a battle because I've liked to once or twice order it separately, and it sometimes gets into trouble insurance-wise. Just FYI. So we use it with below T-score below 1, which just means osteopenia, and these are some of the criteria. Women over 70, men over 80, if you've had historical height loss, self-reported but undocumented vertebral fracture, prospective height loss, steroid treatment for greater than 3 months over 5 milligrams a day. So these are all criteria that you can find, and the National Osteoporosis Foundation is a great website for patients and clinicians.
How would we order that in Epic?
Oh, it actually is
Or
an
you just
Epic.
got a call, it isn't?
No, it is. If you go into imaging and DEXAs, it'll give you a list of
And you have-
standard DEXA or DEXA plus vertebral assessment. So you can actually do it.
Great.
So it's in my favorites. Yeah.
It has been done by the same machine?
Yes.
Yeah.
Yes. So it's on the same machine.
Okay.
Yeah. It is a program on our machine. Yeah. Okay. So the majority of fractures occur in patients who have osteoporosis. Is that true or false? How many say true? How many say false? Oh, so a smart group. Why? Why did you all say that? I mean, the question sounds like it should be false, right? I led the witnesses, but why? Anyone know? Any ideas?
Most likely by the time they have osteoporosis. I mean, first they have they have been known and maybe they are getting treatments. They get the fractures before going into osteoporosis.
They
And
do.
you mean osteoporosis as defined by the
T-score, yes.
It only explains about a third of the variation in patients. It's our gold standard, but it's not that great.
Right. It turns out it's really a numbers game. So if you, it's a little confusing, but this is a great study by Ethel Cyrus, who's a bone researcher at Columbia. And so she looked at the number of women with fractures and their bone density T-scores. So it turns out that the greatest number of, let me see, I think I have this, fractures occurs in women with T-scores of -1 to -2. So, and that's the dark bars, number of women with fractures, and this is fracture rate, the light gray bars, according to T-scores. So the point is, there's so many more women with osteopenia who fracture, okay? But if we said your risk of fracture according to your T-score, yes, the more osteoporotic you are, the more likely you are to have an osteoporotic fracture. Does that make sense? So it's just that there's so many more women with osteopenia, and this is based on women, this study. But anyway, and also remember, age is an independent risk factor for having a hip fracture. So if you're a woman and you have a T-score -2.5, if you're 50 years old, your 10-year probability of having a hip fracture is 2.5%. If your T-score didn't change and you're 70 years old, your risk of having a hip fracture is about 12% over the next 10 years. So age is an important predictor of having a fracture. So something about aging confers fragility to our bones, I think, is the take-home message. Okay.
Just a question.
Yes.
Is osteoporosis related to the severity of fracture?
Severity of
Of
fracture.
like how bad is a fracture?
No,
There's
no.
any study?
No, I mean, I'm not sure how you grade severity of fracture. You mean like arm versus hip?
Or displaced versus non-displaced, or?
Oh, yeah, no, I think that's really a matter of how you fall,
Okay.
which is a whole other, I know you're having or did have a fall lecture. So I think it really depends. Some women might fall and fall directly on their side. Some will go frontward and put their hands out, and the wrist gets the hit more. So I think it's really a matter of the mechanics of the fall. But clearly the likelihood of fracturing if you fall is greater if your bone density is lower. That's an absolute. But yeah, good thought. So we have, and this is a real patient, 85-year-old woman, several medical problems. We're asked to see her for her osteoporosis. She has not had a significant improvement in her bone density recently, but she had a left hip fracture and has been on alendronate since 2005, so a good 10 to 13 years. And she has a remote history of bilateral wrist fractures after a fall. She's had some height decline. No kidney stones, weight loss, cancer, chemotherapy, no thyroid problems, so all the basic, otherwise ruled out. She does have heart disease, hypertension, arthritis, and depression. Neck pain related to her arthritis, no other. Independent ADLs, lives with her daughter, walks around with a cane or walker, gait and balance are a little unsteady. She does walk daily, about 10 loops around the house, also working with physical therapy after a recent TIA. Only source of dairy is Boost once a day. She takes a multivitamin, calcium supplement, but doesn't know the dose. Wears dentures, no issues. She has spine kyphosis and scoliosis and a small thyroid nodule, which we won't need to talk about. Labs are all, essentially pretty good. Normal thyroid. Vitamin D 51, which is quite robust. Her NTX is 24, so that's a measure of bone breakdown, and that's a fairly good number, usually under 30, and she's on alendronate, bisphosphonate. Here's her bone density. So this is, when you see this, it's all bets are off because there's a lot of arthritis. And what does arthritis do to the bone density? Makes it look better. So a lot of times you have to look at the picture to see this. Yeah, I think this is it's not usable really. But clearly her hip is, and she's quite low. So now I didn't know where she's been in terms of prior bone densities, et cetera, but she's been on therapy for over 10 years. So should we do any other imaging? So these are some of our questions. Is she getting adequate calcium and vitamin D? Has she been on alendronate too long? Would you continue to treat her? If so, what medication might you use? So these are all some of our considerations. So I'll just say, in terms of other imaging, would anyone want to do anything else? Would you want to do a vertebral assessment?
She was complaining of negative.
Yeah.
With her shoulders.
Yeah, so more than likely degenerative. But, I mean, you could investigate that for sure. But would you do a vertebral assessment?
I mean, we already know she has osteoporosis. How is it gonna add to our information?
Okay, reasonable. It might, well, she's had osteoporosis, she's had the worst hip fracture, so if she has compression fractures, it might be important either to document or we might think about more aggressive therapy. So it might confirm that. Turns out when you have such arthritis in the back, sometimes it's not a good study when you look at a patient laterally. It may be hard to really define the vertebrae. But I might try. I'm not sure it will change what I do. I agree. So how do we go about treatment? Well, of course, we want everyone to be on enough calcium, about 1,200 milligrams a day total in diet plus supplement. Okay. So adequate calcium intake is important. Direct evidence of fracture prevention is lacking, and this is what you hear on the news a lot, the popular press. But we still do believe that patients, particularly with osteoporosis, need adequate amounts of calcium. And I think when we hear all this new stuff, it's really more public health, so for general overall health. It's not specifically toward patients with significant osteoporosis or bone health compromise. Inadequate calcium intake has been associated with bone loss and increased risk of fracture by association. And there are studies, and I didn't go into detail today about this, that show patients are calcium deficient or insufficient. You give them calcium, you may raise their bone density 1 to 2%. So it's a very modest effect. But the fracture data is challenging because everyone who takes calcium has vitamin D, and you have to tease the two out. And there's a whole literature on this that we're not going to get into today. So consumption of calcium-rich foods and beverages, preferred option. Then we go to supplements when dietary intake is not adequate. Okay, total of 1,000 to 1,200 a day. Don't forget, there is calcium in the multivitamin. And a lot of our seniors are on like a Centra multivitamin. Has a few hundred milligrams of calcium, 220, something like that. Yeah, I go to the drugstore and I'm always looking at these things. So, as I said, some evidence that bone density can improve. Now, it's not a more better. Some patients want to take 1,500 to 2,000 milligrams of calcium. I don't recommend it. We don't have good evidence for that. Maximum 1,500. Okay, here's your next little quiz. How much elemental calcium is there in 1,000 milligrams of calcium carbonate 3 times a day? A, 3,000 milligrams, B, 1,200, C, 1,500. So 1,000 milligrams, if you go to the Tums bottles and it says across the front 1,000 milligrams, you know, in big Tums EX, does anyone know how to interpret that? Tums is calcium carbonate. Anyone have a thought on what the answer might be? C, in 3 pills.
I think it's B.
How many say B? Okay, it actually is B. So calcium carbonate is 40% elemental calcium. So some bottles like a Tums, you have to really read the fine print. And on the Tums bottle, it's a hard one to find. So each one is 400, so 3 a day is 1,200. I tell patients don't take more than 500 to 600 at once because you won't absorb that much. And a cup of yogurt, a glass of low-fat milk, or even Boost. I've looked at the Boost. It's about 250, 300. Okay. So part of our job is to understand and teach patients about looking at their bottles. And the other thing is that when it says calcium, it's very hard to read RDA. The RDA for calcium is 1,000 milligrams. So it says 1 serving is 100% RDA, then that will be 1,000 milligrams. But one serving may be 2 pills. So it's really about, educating the patient. I have some handouts for the patient, because I think that's important. And I do this every other day, asking patients about what they're taking. And how much vitamin D? Well, we usually say 600 to 800 a day. We can, of course, measure vitamin D, and I do not encourage any more than 4,000 units a day. I find patients who come in taking 5,000 a day, 10,000 a day, and naturopaths tend to ask patients to take more vitamin D. There's no good evidence that vitamin D levels above 30 to 32 are going to be any better for bone health and a lot of other things. So I aim for mid-30s. But it seems like with all our multivitamins, calciums, they all have supplemental D. So patients come in level, and we measure them all the time, 40s, 50s, 60s. So I'm often trying to lower that because of toxicity. Now it takes a lot of D to become toxic and become hypercalcemic because it's absorption of increased calcium or kidney stones and that downstream effect. So sometimes I am telling them to take a little less. And you can get vitamin D3 in 1,000 units, 5,000 units, health food stores, more than that. Okay, so let's just keep going. So for medicine, of course, you all know about bisphosphonates. I have another case too. And these are the ones we use, and the zoledronic acid is the IV formulation. And remember, they work by inhibiting the osteoclast. Remember that bone biology, those slides at the beginning. So the bisphosphonate actually gets into the bone matrix and it sits there, and then it's engulfed by the osteoclast, and it poisons the osteoclast, destroys its cytoskeletal machinery, and cell death by apoptosis. So what I always say is the bisphosphonates sort of murder the osteoclast, whereas you'll see the rank ligand inhibitors do something a little different. So of course it works, increasing bone density over 3 years on this study, okay, the hip, femoral neck, and spine, and lowering the risk of hip fractures as well. So we know they work, we know they're good drugs. They have to be used in patients whose renal function is appropriate, above 30 cc's per minute. Okay, let's see what else we got. Oh, how long to treat? Biggest question. Everyone thinks there's the 5-year rule and it's magic. At 5 years, you stop. That is information from one study, just so you guys know. So there's no absolute recommendation. When you stop a bisphosphonate, you actually will see increased benefits on bone density, or continued benefits, I should say, because the bisphosphonate is sitting in the bone. Its half-life is months to years, depending on which bisphosphonate. So you still get that effect, which is nice. So you may not continue it, but evidence for efficacy beyond 5 years is limited. We just don't have the data. Now, some patients have been on it, like this one, for 12 years. It hasn't harmed her as far as we can tell, but it sounds like she's plateaued. And of course, the safety concerns, osteonecrosis of the jaw and atypical fractures occur beyond 3 to 5 years. So that's where that comes from, and a big study called the FLEX trial, it looked at bisphosphonates for 5 years on and then 5 years off. Seemed like on the off period, after the 5 years on, patients' fracture rates were actually quite low unless you had a high risk for vertebral fractures. So it is reasonable to discontinue them after 3 to 5 years in those that are at modest risk of fracture after that initial treatment period. But in contrast, for those who are at high risk of fracture, continued treatment or alternate therapy may be considered. Okay, so I think we've got that one covered. So this is denosumab, which is also known as Prolia. I don't like to use brand names, but you guys have heard of this one. So this is the monoclonal antibody to rank ligand. And let's see, this is the schema, how it works. So the osteoblasts in the bone marrow produce rank ligand, the pink dots. Rank ligand will stimulate through other cytokines the osteoclast precursors, and you differentiate toward osteoclasts, which are the bone resorbing cells. So wouldn't it be nice to have something that stopped this process? And that's what denosumab does. So the osteoblast also makes something called OPG. So this is the balancing decoy receptor for rank ligand. So this is the normal break on the system, and denosumab actually does the same thing. So it binds to rank ligand so that the osteoclast cannot differentiate. So I call it the birth control for the osteoclasts. They don't form. So that's how I remember them, and I know I've taught in clinic. And it works. It works very beautifully. It builds bone, and this is up to 8 years. It's called the Freedom Trial. This is the patients who got denosumab versus those who started on placebo, then switched. And this is just at each site. So the interesting thing about this drug is after 8 years, you're still increasing your bone mass. It's not completely clear why that is. You know, where's the bone being built up? And that's being looked at for sure. And of course, fracture reduction, because that's the biggest thing we care about. And it also works quite well in terms of decreasing vertebral fracture, hip fracture by 40%, non-vertebral fractures by 20%. So when patients ask me, this is kind of what I tell them: 70% decreased risk of hip fracture, vertebral, 40% of hip fracture. Now I saw a 97-year-old yesterday who was on denosumab for several years. She just had a hip fracture. Remember, did you see her?
Yeah.
And so it's not 100% guaranteed. But so 60% can have hip, but when you're 97, if you fall, high risk. So it is approved for postmenopausal women. It's also approved for men with osteoporosis or high risk of fractures. And it's given subcutaneously every 6 months, and then it's out of the circulation after 6 months. Okay? So the patients have to come into the clinic and get an injection, but it's very quick. And there is safety data. You can use it down to 15 to 30 cc's per minute. So that's a little advantage over bisphosphonates. Okay? And of course, jaw necrosis and atypical fractures are the concerns with bisphosphonates and denosumab. And those are the pictures. It's a very rare event in our osteoporosis population. Oops. So I won't belabor this, but basically you see this much more when we use these drugs in the cancer setting, where they're used every single month, and for denosumab at double the dose. So clearly a very different risk profile. That's the main take-home message here, I think. So, okay, this is one of my favorite slides. This is osteoporosis of the jaw and other risks, comparative risks. So, oops, okay, so you're more likely to be murdered, die in a motor vehicle accident, have anaphylaxis from penicillin, have a hip fracture or any fragility fracture, then get osteonecrosis of the jaw when we're treating an osteoporosis patient. So that's how rare it is. And then the atypical fractures have very characteristic X-ray features, and they're defined by the American Society of Bone and Mineral Research. We don't have to go into details, but these fractures occur spontaneously, so they're not typically related to a fall, and that's the key, okay? But an estimated 162 osteoporosis-related fractures are prevented for every one of these that occurs. So I think that's important. Especially patients come in, information of a doctor, that's going to give me jawbone necrosis, that's going to give me a funny fracture or I'll have brittle bones. So we have to address those myths. And I'll show you my favorite thing. So there are no risk calculators for who's going to get this atypical fracture, but a prior atypical femoral fracture is the best predictor of a future one. So they often occur bilaterally, not always simultaneously. And the risk will decrease if you stop the bisphosphonate. It'll decrease by 20%. Just remember that bisphosphonate is sitting there for a long time. So duration of bisphosphonate treatment, and Asians have a lot higher risk of this. So our patient who's been on it for 10 to 15 years, I would take her off that regardless, because she's been on it a very long time. So this is the chart I showed of the patient. So the risk, if you take a medicine for osteoporosis for 5 years, less than 1 will have a jaw problem, less than 1 will have an atypical fracture. So I have this in our clinic, and your risk of ending up in a nursing home if you have a hip fracture. So I think that's a picture that tells the story. Okay. And so anabolic therapy. So these are the drugs that really build bone. Parathyroid hormone, it mimics PTH, decreases the risk of vertebral fractures and non-vertebral fractures very significantly. We can use it for 18 to 24 months. And that's by FDA approval because there was an increased incidence of osteosarcoma, bone tumors in rats. Has not been borne out in people as post-marketing analysis, but it's still, that's the black box warning. The problem, I think, with this drug is it's a great drug for menopausal women and men. It's an injection every day, but it comes in a pen. It's kind of like an insulin injection. It is a hard sell in my mind. I mean, my experience. Now, there was data a year or two ago on a patch with this hormone, so I'm waiting for that to be the blockbuster. Okay, and so what happens with this drug is that initially you turn on bone formation. And remember, bone formation usually follows bone resorption. But with the anabolics, it's the opposite. You stimulate formation before resorption. So we have what we call that anabolic window of 6 to 12 months where you're going to build bone. Now, not every patient has read the literature and obeys this, and we look at bone markers to determine their response. But this is the mechanism of action, and you do get beautiful bone buildup within 12 months to 2 years. So we don't give it to those with hypercalcemia, Paget's disease, growing children or young adults, pregnant women, of course, bone cancers. And if you've had a cancer that metastasized to the bones, that's a no-no. Or if you've had radiation for a cancer, typically we don't give it because it can stimulate metastatic cells and abnormal bone. And we don't give it particularly breast, prostate, and lung that likes the bone. If you have a cancer of any of those, we generally don't give it. Okay. And there's a new one on the market that literally just came out, and it's called the baloperitide. So it takes a few years to learn how to say it, but it just came out. And the biggest trial compared it to the prior one, PTH, and postmenopausal women were tested who had low T-scores and or fractures. So women with significant osteoporosis who met the criteria. And basically the punchline is it works as well, if not better, than the one that's established, the PTH or teriparatide Forteo. Maybe you've heard of that one. And it works very nicely. In fact, it works a little bit more quickly at the spine and at the hip. So that may be the advantage, and it has to do with the receptor it occupies and a lot of other good stuff. And of course, it decreases risk of fracture by 86% in terms of new vertebral fractures and 43% in terms of non-vertebral fractures. Once again, a very good drug. We're just getting experience with it now, but also it's a pen. injection every day. Patients tolerate it fairly well. Some of the side effects, they could get lightheaded or dizzy, so important in our geriatric population. I often have them take it at night before bed. Okay. And what about our patient? So is she getting adequate calcium and vitamin D? I think she was close. I don't remember. Because she had Boost, she had a multivitamin and a calcium supplement. So I would ask her to bring in her vitamins and supplements and go over that. And if she's on a PPI, what do? We make sure they take a calcium in the form of citrate. Citrate better absorbed into when you have a PPI on board. Okay. Has she been on alendronate too long? Yeah, I think so. I definitely think so. The question is, what would we switch her to? An anabolic would be okay for her if she would do it, or a family member would do it. Anabolics work better up front than followed by bisphosphonate, but I think we don't have a lot of options here. Anybody have any other thoughts?
What about denosumab?
Yeah, I mean, you could give her denosumab. It's another anti-resorptive. I might actually observe her, because her turnover, that NTX, was nice and low. So she may be protected for a time, so I might even wait, so even though her bone density is low. But I don't know if we're going to protect her anymore from hip fracture. It's a good question. I think it's a good question. If she would take an anabolic, I would definitely consider that. And what med? Okay, and what about exercise? Of course, we want everyone to exercise. She was doing her loops around the house as best she could. And what about the men? I did have my exercise. Okay, quickly on men. So men, of course, one of the major risk factors is low testosterone. Okay, and men also, if you have low testosterone, you have low estrogen, and we've learned over the years that estrogen is important for men's bone health. And these are all the other risk factors. Men on prostate cancer medicines, very important to look at bone health. These are just a few things. So this is a true case, 76-year-old male. I saw him at the request of his geriatrician for acute back pain. He had a prior history of a compression fracture a number of years ago related to golfing. He lost a half to 1 inch of height, history of remote hepatitis as a student, retired, married, non-smoker, a little bit of wine, good calcium and diet and supplement, and really good lifestyle choices. Golfs 3 to 4 times a week. He walks, he goes to the gym. He lives, I think, in Doncaster. So when I saw him originally, he had very significant back pain, and he was depressed because he couldn't play golf. And his goal was to get back to playing golf. And so this was the recent fracture he had. And it doesn't look like much, right? But it's caused a lot of pain, as fractures do. Okay? And this was his bone density. So the surprising thing about his bone density, here's L1, that's where his fracture was. That looks like a normal, good height. It's because you're only seeing the area. If you turned him on his side, that's when you see the compressed area. But interestingly, all his vertebrae were very low, because sometimes if you have that compression, that vertebrae will look much different in terms of its T-score than the others, okay? But his wasn't, but he had low bone density at the hip as well. So here's all his lab data. So here was the interesting thing about him. He had a total testosterone of 407, very high binding protein, which we never quite figured out why, although hepatitis was his history, it wasn't active. Hepatitis can increase binding proteins from the liver. And his free testosterone was 36, so that was low compared to normal. And there is something called bioavailable testosterone. What does that mean? That is testosterone that's free and testosterone that's bound to albumin. that is the testosterone most available to the tissues. So I measure that sometimes when I see a lab like this with this high SHBG. And he was low, not super low, but he's one of those guys, falls in the middle of should we or shouldn't we give him testosterone. And his NTX was elevated, bone out phosphate, so turnover was a bit elevated, good vitamin D level. So would you give him testosterone? Or what would you think about? Any thoughts?
And we're assuming his hematocrit is normal?
Yeah, hematocrit, PSA, I mean, those are all things you have to check. Yeah, I didn't put it, CBC was normal.
Oh, excuse me.
Yeah, yeah, but you're right, good point. So I did give him testosterone, I did. He took it, he was on it a number of years, and he did well. And then I also added Reclast, IV zoledronic acid. So we got some little boost out of the testosterone. He felt better from his fracture. He got back to golfing in about 6 to 12 months. It took a while, and that was just the pain from the fracture. Now golf, you're swinging like that is tough on your vertebral column, especially when it's -4. So, and he's had prior compression. So testosterone, most studies, the effect of testosterone on bone are mixed results. Very confusing, because how do they measure testosterone and who gets into the study? But there's a current trial, it's called the testosterone trials. It's everything you ever wanted to know about testosterone and its side effects, its effects on the heart, on anemia, sexual function. It's a great review. So they looked at men who were mildly hypogonadal. So this is the classic patient you see in the geriatrics clinic with a testosterone a little below normal and less than 275 nanogram per DL, and our normal is like 300 to 9 something. And they treated them with androgel, and had 211 men for 1 year. They did find an increase in bone density, and they did it by something called volumetric bone density, QCT. So that's a 3-dimensional imaging, and they found a significant increase at the spine of 6.8% more than placebo, and the bone strength, they could measure bone strength at trabecular bone, and that was also increased. So testosterone is good, but right now we have no data that shows it will decrease fractures in men. So that's why if you have someone who's had fractures, I put them on testosterone and then probably an osteoporosis med. And that's what I did with him, but I wanted to do one at a time. So these are just the studies, and these are just the meds that are approved for men. So we do have a good amount of choice. Who should have a bone density? Men who've had low trauma fractures. On x-ray, sometimes you see osteopenia in the report, so those men should be evaluated. Low body weight or loss of 10% of one's body weight is an indicator. And then men with other clinical conditions like chronic steroids, getting prostate cancer meds, chronic medical disorders. The National Osteoporosis Foundation says all men over 70, those with a history of fracture, and with risk factors if they're 50 to 70, so under 70. And last but not least, we want to talk about exercise. Remember, there's weight bearing and resistance training. Patients mix this up all the time. So the weight bearing means activities making you move against gravity, like walking while you're standing upright. It could be high impact dancing, jogging, jump rope, or low impact walking, elliptical. Now then there's resistance exercise. So moving your body against resistance, weight training, bands, weight machines. So you want to, if a patient can do both, that's great. If they can't, I say go walk, go upstairs. Gardening is very good. Yoga and Pilates, because everyone's doing that, right? Very good for strength, balance, and flexibility. Some positions should be avoided, particularly forward flexion, because coming up you put a lot of force on the back and on the vertebral column. And then this is about Tai Chi, a meta-analysis. The problem is the studies, I'll show you the bottom line, was that the measurable effects are limited, but the methodology in the studies is challenging to get the real answer. And if you, I'll show you just this, the effect of Tai Chi versus no treatment on spine bone density, it looks like it's good. But here, if you put them on calcium alone versus calcium plus Tai Chi, no real difference. But remember, the methodologies in this meta-analysis, when they looked at the best of the best studies, was challenged. So this was also about another study about dieting obese older adults. This was in the New England Journal last year. And they took 140 obese older adults, evaluated several exercise modes in reversing frailty and preventing loss of muscle and bone mass. These were patients who were very mild to moderately frail, because how would they be able to do aerobic training 40 minutes 3 times a week, resistance training 4 times a week, and a combined program of even longer duration, up to 270 minutes per week. But they did have some interesting findings. Everyone lost weight as they were supposed to, and they found that aerobic exercise showed great improvements in cardiorespiratory fitness, as we would expect. Resistance training, greater improvements in strength, but the combination group, that's resistance plus aerobics, had the greatest improvement in physical function. They found that weight loss alone was harmful with respect to loss of lean body mass and also bone density, but if you added resistance and aerobic, you could attenuate the loss. So I thought this was interesting on the total hip bone density. Aerobic exercise, the patients actually lost bone, but if you combined aerobic and resistance, you maintained bone. So actually the best combination was the two. Okay, so we know osteoporosis and the subconsequent fractures are a major health burden in our older population. Secondary prevention is a national effort. This FLS, Service Fracture Liaison, and of course primary prevention for those who are at risk. Benefits of treatment still far outweigh the adverse effects, so goals of treatment are important to consider. Optimal duration of treatment and the sequence is not exactly absolute or clear, still work in progress. And don't forget about men, it's important to recognize, evaluate, and treat them. Okay? So that's it. Thank you. And questions, comments? Hard to cover everything. Yeah.
So I do mostly post-acute care, so I take care of a lot of hip fracture patients. So I would be interested to hear your thoughts regarding the timeliness of initiation of oral bisphosphonate therapy. I know that there's data that suggests starting it within 2 to 12 weeks post-fracture, but
Right.
those studies were only done with IV bisphosphonates, like
Right.
hyaluronic acid. So do you know of any data that suggests that oral bisphosphonates has the same benefit?
Yeah, there's no studies. The best one is the Horizon
Right.
fracture intervention trial. So they started within 2 months, so, like you said.
Yeah.
So, don't know, but if I use an oral, I use a Lendronate because it is the more potent oral bisphosphonate. And if it works for some, it's inexpensive, if they can take it and tolerate it. A lot of the older patients, I think just giving, if they have the renal function, give a single dose of IV Reclast and they can go off to wherever they're going in the home.
Because that's one of my concerns, because a lot of the times, these patients, are very frail or they're transitioned,
Yes.
Potentially to long-term care. So initiating an oral, at rehab for patients that are transitioning to the
Yeah.
community, it's kind of already starting the process for,
Yes,
a
yes.
PCP that's already has, this multi-morbid patient with a new hip fracture. So I know
Yeah.
that there's some concerns regarding, the timeliness of bisphosphonate therapy with regard to fracture healing.
No.
Okay, and there's
No.
concern, and there's nothing proven with
Yeah.
that though, but
No,
sometimes
they
the
actually,
surgeons worry.
so our bisphosphonates we use now, they are proven to not have any inhibition on fracture healing. So I think in what the scenario you described, you want to capture that patient. You can't give them IV request in the hospital. Well, that's challenging, and it's right after the fracture. Nobody's looked at that. I mean, you probably could, but if you have to give them an oral, I would give it. It's better than not having anything on board. You started it. Hopefully the PCP will continue it.
Right.
It won't inhibit healing. Bisphosphonate, the only one was a very old bisphosphonate that was shown to inhibit healing, but the newer ones, denosumab, do not inhibit healing. There is decent data on that. I can't tell you off the top of
Oh,
my
no,
head.
no, it's just some of the older surgeons that I work with, that's sometimes some of the
I know.
concerns, so I'm trying to educate, I think, our colleagues is also
Absolutely,
important.
absolutely. But yeah, I think if you have a captive audience,
Yeah,
you have to
for
take
sure.
advantage
Yeah, absolutely,
of it. Yeah,
absolutely.
yeah, that's a good challenge. But any other comments?
Thank you.